Good morning, everyone, and Assalamu alaikum. My name is Dr. Farina Hanif, and I will be presenting the topic for management of gastrointestinal foreign bodies. So basically, the reason of presentation of this topic is that there is controversy regarding the management of foreign bodies. Every foreign body need not to be removed either by endoscopy or surgery. So there are also some different approaches which have been prescribed by some guidelines for adult and pediatric age group. So I will be dividing my presentation into two groups. One, initially, I will be discussing the frequency, how to diagnose the foreign body ingestion, and how to prepare it for the endoscopic removal. In the second part, I will be explaining other different recommendation for different foreign bodies. So frequency, we commonly see in these foreign bodies in children, and usually this is accidental, but in cases of adults, they can be due to suicidal intention or any psychiatric or mental illness. Majority of these cases are removed, they are spontaneously comes out through the natural orifice in 80 to 90% of the cases. Only around 10 to 20% require endoscopic removal. Less than 1% requires surgery to remove the foreign body, either to remove or either to treat the complication associated with ingestion of the foreign body. So patient can present with complaint of dysphagia or odynophagia. There is drooling of saliva. Patient may have a feeling of foreign body within the throat. And in cases if it involves the respiratory system, the patient can present with wheezing and dyspnea. These are the alarming features, and we need urgently go for the endoscopic procedure. So whenever patient comes to our emergency with a complaint that he or she has ingested the foreign body, the important questions to ask is that how many, what type of foreign body, did the patient had food before or after that, and what have the time elapsed since the foreign body was ingested or the food was ingested, and now currently what patient has been symptoms he or she is having. For the physical examination, the most important is the resuscitation, airway, breathing, and circulation should be followed to ensure that for the safety of the patient. Even if the patient is asymptomatic, every patient with foreign body should be admitted in the emergency, and a radiograph should be done to see what is the type of the foreign body, the location, and the number of foreign body. And this radiograph involves the neck, bidirectional. It is important in case if the patient has ingested some spherical object to differentiate whether this is a coin or a battery. And we also have to have a chest or abdominal X-ray, and even pelvis if the foreign body have ingested through the anal area. If the object is radiolucent, sometimes the children come with wooden toys or anything which cannot be seen in the X-ray, we can go for a CT scan. Nowadays, there is a role of point of care ultrasound we can do for the radiolucent objects. So another purpose of doing the radiograph is to evaluate there is any complication, which is perforation, to see any mediastinal or peritoneal free air. In cases when the free air, we are suspecting the patient is very symptomatic, but there is no free air in the X-ray, we can go for the CT scan. The important point is that MRI has no role in the radiolucent foreign body ingestion, but in case if the patient has taken the battery, ingested the battery, MRI should not be done unless the battery has been removed. The other thing which I said, the point of care ultrasound, we use in one patient. I will be discussing that case later. So when we know that patient has ingested the foreign body, we have taken the history, now is the time when to do the endoscopic procedure. So it's actually dependent on multiple factors. It's depend whether what is the nature and the size of the foreign body, where it is located, what are the symptoms of the patient, whether patient is symptomatic or asymptomatic, the time period, whether the NPO status, the family anxiety, and the experience of the endoscopist. So the guidelines have divided the endoscopic timing for the endoscopic procedure into emergent, means within 2 hours or less than 6 hours. It doesn't depend on whether the patient is NP or not. Because patient is severely symptomatic, we have to intervene emergently. In cases of urgently, it is done within 24 hours. We can wait that if the patient has taken food and the foreign body in the stomach, we can wait that let the food particles go out of the stomach for the easy removal of the foreign body. Usually in adult it is recommended to do the endoscopy in conscious sedation, but general anesthesia in cases of children and adults in special cases can be done, like if there is a high risk of aspiration, like patient have eaten food like 1.5 hour ago or like half an hour ago, or there is the esophagus, the foreign body is in the esophagus, or it is a food bolus impaction, then we know that there is a very high risk that when we will be removing from the esophagus, it will go into the respiratory tract. So we need to protect the airway. So ETT should be placed. When the foreign body is suspected that it will be difficult to remove, there are multiple objects, and if we are using rigid esophagus, this EGD, rigid EGD is usually not used by the gastroenterologist nowadays. Even in children, it is preferred to do in ETT because the airway is very soft and it usually collapses with the foreign body or with the esophagus with the EGD. So it is advisable for the children to go for ETT before removing the foreign body. In cases when the object is above the cricopharyngeus muscle, it is the ENT surgeon can remove it. In other cases, we can remove with this forceps called Magel forceps, or there is another maneuver which can a radiograph usually under fluoroscopy by the radiologist done, that a Foley's catheter is passed under the fluoroscopy beyond the foreign body object, and then the balloon is inflated by a contrast, and then with the slight traction, this foreign body is extracted out through the Foley's bed. But there is a risk that this foreign body will go into the stomach, which is also preferable for us, that because it is easily removed from that method. So when we know that we not need to do the EGD, now for the preparation of the removal, it is advisable, if you are not familiar with the foreign body, whatever instrument we are planning to use, we should be rehearsed outside the stomach, and to see whether the object will be grasped by the instrument or not, and which instrument should be taken out. And another thing is to do a radiograph just before the endoscopy to do, to see whether it's still in the same position or it's have moved out. So in our institute, we use a fluoroscope assessment to do before on the table of the endoscopy to see whether it's in the same place or not. So now we are prepared, and as I said in the second part of my presentation, I will be discussing regarding the different objects, how to manage them. So initial, the button and cylindrical battery is a dangerous thing, and we have to do the emergency procedure if the battery is in the esophagus, because it will cause alkaline injury by the reaction of the electrolyte and the tissue fluid. By the pressure of the battery, it also cause more injury. And the third thing is the size. The more the size, the more injury. So it is said that it was shown in a study that if the battery is more than 2 centimeter, within half an hour, it can cause perforation or any aortic enteric fistulas. So it's very urgent whenever a patient comes with a battery. First, we need to rule out whether this is a coin or battery, and then we have to intervene as soon as possible. So this is a diagrammatic one of the endoscopic procedure. This is the battery which was placed, it is in the stomach, and as you can see, within 3 hours, necrosis have already been started in the stomach. The complication associated with button batteries include fistulas, perforation, stricture, even cardiac arrest or pneumothorax if it intervene into the esophagus, the pulmonary tract. So as I was saying, that it has to be, if it's some cylindrical object has been ingested by the patient and they are not sure whether this is a coin or a battery, a radiograph should also be done, not in one angle, also another triangle, to rule out a double halo sign. So this is a double halo sign. As you can see that there is some whitish material and there is a grayish halo around it. This is a representation of a battery. So it is very important in cases of the esophagus. In stomach, usually we cannot see the halo because it's usually lying down. So as you can see that there is, whenever there is a battery, the inflammation start very frequently, and there is a mucosal necrosis can already be seen on the EGD. And this is done weeks after the endoscopy, and we can see a very necrotic patch and healing, which is taking a longer time to heal in the esophagus. This is the instrument I was talking about. This is the usually we use raw tooth forceps or a grasping forceps with a net inside. So it holds the object within it and it closes it, and it safely can be removed. So So the other thing is that, as I was saying, that if it goes into the stomach, we are not on a safer side because they can be esophageal injury. They can also, the longer it stays in the stomach, it will cause more injury. So whenever patient has a battery, we have to do the radiograph to rule out any perforation or fistula at that time. And these are the recommendation for the management. It is divided into two parts if the battery is in the esophagus or in the stomach. So as I state, if the patient is stable, still we have to go for an emergent endoscopy within 24. But if it's unstable or there is bleeding, like if there the aorta is involved, then we need to go for CT angiogram, and the procedure should be done by the endoscopist and the cardiovascular surgeon in a OT, because there is very high risk that there will be an aortic injury. Even after the removal of the battery, we have to follow the protocol of corrosive injury to rule out any perforation and to follow up later on to form there is any stricture formation later or not. While in case of the stomach, we need to see whether the child is less than 5 years or more than 5 years, and the size of the battery. Because of the size of the battery, there are different recommendations. Some prefer to do it within 48 hours. Some prefer to do it within 24 hours, or some says that if the size is very small, we can follow. But in any case, whether it is in the esophagus or stomach, if the patient is symptomatic or we know there is some anatomical pathology, emergent endoscopy should be performed. So I was saying that because of the different guidelines, the American Society recommend that if the size of the battery is more than 2 centimeter, and if it's and we can follow it, and if within 48 hours it has not moved out of the stomach, then shall we intervene. While the North American guideline recommend that it should be removed within 24 to 48 hours. But some other guidelines recommend that even the size is less than 2 centimeter, it should be removed within 24 hours because of the risk of injury. Then there is another form of batteries, the cylindrical one, which we use in our remotes and everything. So in cases, if it's in the esophagus, any part of the GI tract, and patient is symptomatic, or there are multiple batteries, it should be urgently removed. While in case if it is in the stomach and the patient is asymptomatic, we can wait for 7 to 14 days. So this is the an endoscopy of a patient which has had ingested a cylindrical battery, and there is an area of erosive foci, and it was removed by using this grasping forceps with a basket. The picture I've already shown. The other dreaded ingestion is the magnet. The problem with the magnet is if one magnet is taken on, it's okay, we can follow it. But in cases if there are 2 or 3 magnets taken, it can go into the different loops, and they combine with the between the intestinal loop, they can form fistula, perforation, or necrosis. And the new magnets in the form of new with containing neodymium, iron, and boron, they are now able to play to be on the desk toy, or and used to play with the children. This object can be converted into different designs, and it can be pulled out. So because this is very shiny, it's very attractive to the children, and they ingest not one, two, because it's very small. And these are the one which have more more magnetic power than a normal fridge. So anyone having small children should not keep this at their home. So whenever a patient comes with a magnetic injection, we need to do a lateral radiograph to see what is the number of the magnets he or she has ingested. If there is multiple, it should be removed urgently because of the risk of fistula and necrosis. EGD and colonoscopy dependent the location of the magnet. The instrument depend what is the endoscopist is feasible with, and or the shape and size of the magnet. Usually the grasping forceps is more ideal. And in case we cannot perform the EGD, like the facility is not available, or it is far beyond the reach of the endoscopist, then the laparotomy or laparoscopy should be done to remove those magnets. So this is also a table which shows that if it is divided into only there is one magnet or multiple magnet. If the magnet is in the esophagus of the stomach, if it can remove, it is okay. Otherwise, we can ask the family to remove all the magnet from the house, that the patient can re-ingest, remove the magnets from the surrounding. Third, this magnetic patterns and any buckle with in the belt should not be placed by the patient or the family, and they can follow with the X-rays. And We can also see if the passage is delayed, we can give some laxative to the patient for the easy passage of the foreign body. However, if there is multiple magnets and whether it's in the esophagus or stomach, it should be done endoscopy within 12 hours. If it is delayed because of any other purpose or there is no surgical facility, then if it's delayed more than 12 hours, then the surgical intervention should be done. In cases if it's below the stomach and the patient is symptomatic, then we have to go for the surgery. If the patient is asymptomatic and there is no sign of obstruction or perforation, then we can go for the endoscopy or follow within 4 to 6 hours to see the passage. If it's not going beyond, even with the use of the laxative, it should be removed either by endoscopy or by the surgery. So there is an X-ray of a patient who had ingested 2 magnet. One is in the stomach, other is in the duodenum. So there is a risk of having an interstitial fistula. Similarly, there is another picture which have ingested 17 beads of magnets and has caused ileal perforation by the ear. The other foreign body is the pointed and sharp objects. These objects are scary because they can cause multiple injuries, which include perforation, migration into the different organs. It can cause abscess or peritonitis and even cause common carotid artery rupture or aortoesophageal fistula, depending where it is located. So we just not need to save our endoscope, but also the patient. So it's preferable to use an overtube or a protective cap over the endoscope. Similarly, these caps are like same we use for the band ligation, and it's protect the esophagus from the trauma. It is because it's a sharp object, or in cases if it's a multiple object. We can also use a laryngoscope if it's above the cricopharyngeal area. If the patient is asymptomatic, it is preferable to keep the patient MPO because finding that sharp object in the food is a difficult thing. But if the patient is symptomatic, we don't have an option and we have to do within 2 to 6 hours. So if the object is radioic and it's in the esophagus or stomach, we have to go, depending upon the NPO status and the patient symptomatic or asymptomatic, we have to go for the endoscopy. If it's beyond if it's in the small intestine, then we can go for it's beyond the second or third part of the duodenum, and we cannot intervene through the endoscope. We can go for endoscopy or a surgery, or we can follow up with the radiograph if the patient is asymptomatic. And if the object has not moved from the 3 days, then it is better to go for a surgery because the endoscope cannot reach there. In cases, if it is a radiolucent, we cannot see through our X-rays, and sometimes CT is preferable in cases if it's asymptomatic, and we can follow it like. Otherwise, we have to, if the patient is symptomatic and there is a radiolucent object, we have to go for the endoscopy. So this is the recently, a week back, we did an endoscopy on a patient who ingested this medicine with a blister pack. So it has a sharp end. The patient has brought us the medicine with him, that this is the one I accidentally ingested, and it was stuck in the 20 centimeter from the esophagus, and it was removed by the grasping forceps with the net. And the patient was presenting with the complaining of drooling of saliva, so we have to intervene urgently. And we cannot see this on the radiograph. The other foreign body is the food impaction. It is very common, and it is seen more commonly in adults with eosinophilic esophagitis, reflux esophagitis, any patient with post-anastomotic stenosis after the repair of the fistula, or any motility disorder. It is preferred to use an overtube in cases of adult, but not in children because of the risk of perforation. And the overtube is used because we have to go in and out multiple times to remove the food bolus. So it is also advisable in cases when patient present with food impaction to take biopsy for eosinophilic esophagitis, because that can be the first presentation of the patient in cases of eosinophilic esophagitis. So this food impaction can be removed. En bloc means we can remove the entire piece of that the food bolus, or it can be broken by the snares into smaller pieces, and then we can remove it. The third thing we can do is then push the food impacted food through our scope gently. If it possible, it's not injuring the esophagus, and we can push it into the stomach, then it is safe for the patient and easily removable by the endoscopy. Same thing which I said, that it's depend upon the patient symptomatic. Usually the food is stuck into the esophagus and patient is quite symptomatic. He's not able to even tolerate his saliva or take a sip of water. So it is preferred to do emergently in cases of symptomatic patients. The second last object is the coin and the blunt object. The coins are the most commonly seen taken by the children, and it is advisable to remove within 24 hours. The most common thing which I'm saying, that if any spherical object come, it should be differentiated by a battery, by a double hello sign in the radiograph if possible, because the battery, in cases of button batteries, we have to intervene as early as possible. So we have to see that if an object is more than 2.5 centimeter in cases of young adult, it will not cross beyond the pylorus. And if it is more than 6 centimeter, it cannot pass through the duodenum. So in any patient presenting with these measurement, which we can easily measure on the radiograph or a CT scan, we have to remove them endoscopically. So same scenario, in cases of symptomatic, we don't wait, we do the procedures. While in cases of asymptomatic, we can do the urgent endoscopy if it is in the esophagus, but before doing the procedure, we have to do the radiograph to see whether it might have gone into the stomach. If it in the stomach, we can wait and watch, and it can be followed by in a 1 to 2 week interval, or we can use laxative. If it is not passed beyond 2 to 4 weeks, then we can intervene endoscopically. In cases of small intestine, we can watch, and if the patient becomes symptomatic, we can go for the enteroscopy or surgery. So this is one of the patient she was a 10-month-old child who ingested a screw. The size of the screw was 1 centimeter in length and same in the width. So it was followed from the stomach, and within 2 days it came out through the stool in the patient. This was seen in the descending colon after 1 day. And the next day, in the second day, the patient evacuated the screw, and no laxative was used in this patient. The same thing, that we can use the raw tooth forceps instruments and the grasping forces for them. Sometimes we can push the coin in the esophagus by the NG that can easily go into the stomach and can be easily removed. There is also an example of a blunt object, because these marbles are colored, so they become radio opaque, so they are easily seen in our endoscope. One of these balls are representative of super absorbent objects. These are the ones which are newly available nowadays in the market. It is used even in the vases to provide water to the plants. So what happened? These balls actually ingest large amount of water, and they expand and become bigger. The problem we face in managing in these cases is that they are not radio opaque, and we are not able to see them through the radiograph. So they can be ingested, and then they can obstruct in the later part of the GI tract. So these are the objects which we might have seen. It also are available in the white transparent. And if it is advisable, if they're less than 1 centimeter, we don't need to intervene. This is one of the patient who was a 3-year-old child who has ingested it. The family said it has ingested large amount of it, and we did an ultrasound for that patient. And because it was involving the whole of the stomach, we intervened. And then when we intervened, it found out that the child has actually chewed the balls. So the balls were not expanding with the water, but all the material was mixed with the food. So everything was removed by endoscopically, doing the procedure multiple times. There's also an example of a super absorbent object. It was done in a patient of 2 years who presented with multiple vomiting. And when this object was removed, it was not found out what was the object, but it was assumed that it is something which has absorbed a large amount of water. It has expanded and then become solidified. So in conclusion, depending upon the timing of presentation, the size of the foreign body, and the type of the foreign body, we can decide the timing of our endoscopy. In cases of battery, our sharp pointed object in present in the esophagus, we need to do it emergently within 2 to 6 hours for the patient benefit. Thank you.